Hello, everyone. As promised, this is the video for anesthesia modifiers. I will try to be succinct, but you all know that is not my strong suit, but I will try. Okay, so we're going to look at modifiers in these three categories. These are the same modifiers that are listed in your textbook. I don't want you to worry that there are some new mysterious modifiers that you didn't know about. They are the same ones. But as far as I could tell, your textbook did just list all the modifiers together, and that's perfectly fine. If that works for you, great. But this is the way that I learned about modifiers, and I think it helped me understand the process a little bit better and gave me a little bit more context for how things were used. So this is how we are going to discuss them today. So physical status modifiers, that's those P1 through P6. Those are the modifiers that are used to identify the condition of the patient before surgery. It's not going to be something you attach after surgery, even if you know the results. And so they might try to trip you up a little bit on some questions to say healthy patient prior to surgery, after, was on life support or something like that, and try to trip you up a little bit. But it is the condition of the patient prior to surgery. This gives the modifier, or the modifier gives the context to the actual code and helps explain kind of how complex, how risky, how likely there is for an adverse event. So that is why we have those physical status modifiers on anesthesia codes. They are required for codes, but in your homework and your workbook and things like that, you may not always be able to have a physical status modifier, and that's okay. But just know that in the real world, whenever you are actually coding anesthesia, you will need to have a physical status modifier. And they can only be used on the actual anesthesia codes. So those add-on codes we had talked about in the last video, those you could not use a modifier for. Just that 00100 through 01999, okay? So these are the modifiers themselves, P1 through P6. Your book does a great job explaining them, and you will get a lot of practice with assigning them and seeing the kind of language that is used to describe different conditions that might put a patient in one category over another. Most of the time, it is pretty obvious. I think maybe the most tricky might be between P3 and P4, but the difference there is going to be the constant threat to life. So that is what would have to be very clear in the notes in order for you to use that P4. Payment modifiers. So payment modifiers, these are specifically related to the individual who is administering the anesthesia and the circumstances under which they're administering that anesthesia. So it is not always just one anesthesiologist is providing anesthesia to one patient. In fact, it's often not like that. So there can be all kinds of different circumstances under which either an anesthesiologist, a nurse anesthetist, a surgeon, a non-anesthesiologist doctor is actually the one providing the anesthesia or overseeing the anesthesia. And these codes help us understand those circumstances, and they do relate to the actual payment for that provider. So that's why they are very important. So the modifiers that directly relate to payment are these here, and it's so AA is anesthesia performed by an anesthesiologist, pretty straightforward. QX is going to be anesthesia performed by a CRNA under the direction of a physician, while QY is performed by a CRNA, that's a nurse anesthetist, if I didn't clarify that, and that's medical direction by an anesthesiologist. So that's the difference there. QZ is, again, performed by CRNA with no anesthesiologist present. That's less common, but it does happen. AD is going to be anesthesia that's supervised by a physician who's also supervising for more than 4 concurrent procedures. And this is very common where an anesthesiologist or another physician will be supervising multiple procedures that are taking place at the same time. And so this one is if it is more than 4, any amount more than 4. And then QK is 2, 3, or 4. So that's important to note the difference. And I do know these are questions that come up on the national exam. I remember specifically having one that was specified that it was 4 concurrent procedures. And they gave me the option of having AD or QK. And it was QK because AD is for more than 4. So keep that in mind that this can come up on the national exam as well. Informational modifiers, these don't necessarily relate to a different payment, but they do give us a more complete understanding of the circumstances. So they are very important, and that is G8 and G9. G8 is monitored anesthesia care for a complex procedure. So, and then G9 is for a patient with a history of cardiopulmonary condition or disease. And so these give us a more complete understanding of what's going on with that patient when they go into surgery. Helps us understand, hey, this is a very complicated procedure. So even if the patient is otherwise healthy, there could be an adverse reaction. There could be a less than ideal outcome of this procedure because it's so complicated or deep or whatever else is going on with it. And then, or if they already have a history of cardiopulmonary issues that could interact poorly with anesthesia, it's important to understand that. And even if it is something that's in the documentation, when we use modifiers like this, it's kind of like when we were doing diagnosis codes, ICD-10, when we had those Z codes that helped us describe conditions better. That's kind of what this is doing. It helps us describe things better so we can have a more complete understanding of what is going on with that patient immediately when we look at their charts, right? So that is what the informational modifiers are. I'm going to take a second here to actually go to my CPT manual because I wanted to show you how I've annotated this because I know that's helpful for some of you. Okay, so this is the notes page. There we go. This is on page 70. On the next page is where we start anesthesia. That's 71 in the CPT. If you look here, this is where I have written my notes. This is a great page. I would highly recommend you use this page up. Right now, I only have information about modifiers, but I'm sure I'll add more as I go along. As you can see here, I've specified HCPCS because as you might remember from your reading, these are technically HCPCS modifiers. Now, that's not necessarily something that you definitely need to understand every single time you are picking a modifier. However, it is good to know for general knowledge, and then it might also come up in the national exam if they ask, which one of these is a HCPCS modifier. So you don't have to be flipping through all your manuals to figure it out. You'll have it listed here. And then the frequent modifiers, and I didn't do that. So we will go back and we will look at those as well. So these are frequent modifiers that are just CPT modifiers. So I want to show you some about those as well. But I just wanted to kind of show you guys this page that I was using. And then I do have a little reminder here that the physical status modifiers are actually in the guidelines themselves. So I don't need to have it listed here, but if you want to, feel free. So please take advantage of these pages here. All right, I'm going to switch back so we can go over those final modifiers. Okay, so like I said, these were the 3 main categories: physical status, payment modifiers, and informational modifiers. And those are specific to anesthesia. However, we do have some other modifiers, CPT modifiers, that could be used in this section. And it's just good knowledge to have that you may use these as well at some point. So 23 and 47, I feel like are pretty clear: unusual anesthesia or anesthesia provided by a surgeon. But 59, that one might seem less clear. And I actually just did a training on it, so that's why I wanted to mention it. So 59 might be used if you are, if surgery is performed that's pretty complex or might result in a lot of pain after. So the anesthesiologist may place a nerve block at the end of the procedure. So there's two different procedures going on here. We have general anesthesia, so the patient can actually get the surgery, and then the anesthesiologist does a nerve block as well to help with pain management immediately after the surgery. And so that's two separate and distinct procedures occurring at the same time. And so that is when you'd use that 59 modifier. And that's just a regular CPT modifier. And if you're feeling overwhelmed or confused by that, don't worry, we'll get into that more. But I did want to kind of clarify that these are some things you might also use in this section, okay? Okay, so let's do a few examples. And these are both going to be from your workbook. So this is workbook question number 22, anesthesia for myringotomy on a healthy 5-year-old patient. I do want to clarify, if you've not done anatomy and physiology yet, or maybe it's been a while, myringotomy and tympanotomy are the same thing. If you did not know that, that's totally fine. You would just need to look this up in your medical dictionary. And it would probably tell you that, or just do a little bit of research on myringotomy, because I'm pretty sure if you put myringotomy in, tympanotomy comes up. If you put tympanotomy in, myringotomy comes up. They're fairly interchangeable terms. So that should help you when completing this one. So let's go to the actual manual so you can see what we're doing. Okay. So here is the actual question. We are just looking at the anesthesia. We're not looking at the procedure at this time. Baby steps, right? So if we're looking here, now remember, anesthesia goes in order, and myringotomy or tympanotomy is in the ear. If you didn't know that, that would be a great time to actually do a little research, look it up in your medical dictionary. So myringotomy is a procedure done on the ear. We don't have anything in here about the ear, right? We do just start at the head. So we're going to look in this first section, page 74. Here's the head. As you can tell, not a lot of procedures are in here. So we're just going to have to go through and look. And luckily, it kind of goes in order too. It kind of groups together things. So we've got mouth, salivary glands, eyes, ears, things like that are together. There are not a lot of things on the ear. So we start here at 00120, anesthesia for procedures on external, middle, or inner ear, including biopsy, not otherwise specified. This looks like a great option, right? Except if we keep looking down here, we do have tympanotomy. And like I said, myringotomy is the same thing. I would actually write a note here so you can remember that. I actually did another training on that recently, and I didn't know it myself, but now I know. And so I'm going to tell you so you don't have to feel anxious when you see those, those terms, or if it's been a while since you've done A&P. So go ahead and put a note like that for yourself. And then after that, it goes right into the eye. So we only have these 3 codes that we could use. Otoscopy in anesthesia for procedure on external, middle, or inner ear, including biopsy, not otherwise specified. So I would say it's either between this one and this one. And since we know tympanotomy is the same thing as myringotomy, I'm going to go with that one, 00126. Now, are we done here? No, we are not done. I know, isn't that sad? We already know this is a healthy 5-year-old. So we know the condition of the patient. So we can actually go ahead and use a physical status modifier. And it's here right on the previous page on 73. We can look at them. And this is pretty easy because we know it's healthy. Very first one says healthy, right? So we don't have any complications going on here. So we're going to go ahead and put P1. Okay. So we have 00126 P1 as our code. So that's that one. We're going to go back and double check my work. Oh, 126 P1, and we're correct. That's great. Okay. All right, so we're going to do workbook question number 28, and this is one of the notes one, and I am committing to doing more examples that come with reports, because I know those are the ones people hate the most. So I would like to lessen that burden on you. And this is a very complicated procedure that we're looking at. It's general anesthesia with disectomy and osteophytectomy with allograft fusion and Zephyr plating from Z5 or C5 to 6 and C6 to 7. What? This is wild. Okay, let's go ahead and look at the actual report, and then we can look at the manual, okay? Okay, so this is the actual operative report, and you can see there's a whole bunch of stuff going on here. Lots of issues. This seems very, very complicated. So we'll definitely read through all of this. I'm not going to do this now with you because that might bore you. Here's the procedure that's performed. And then if we looked through here, we can see that they did general anesthesia. We've got screws, we've got grafts, nerve roots, removal of discs, all kinds of different very complicated things going on here. We can also go ahead and we can look up these parts of the spine and find out that that's the cervical spine. So we can do a lot of research here. I think that's excellent, very wise to do. But I would also advise you to, if you see something that's complicated, to first go and look at the actual anesthesia codes and see how many are there and what can we derive from those codes that would help us pick the right code here. Okay, so let's go back to the actual manual, and here it is. Now, let's see here. Okay, so remember everything. So here is our, and again, it's 28, but it's report 41. Here's what we're actually doing. And it's just the anesthesia for all of this. So we're not going to come in and code all of these procedures. We're just doing the anesthesia. So let's go ahead and find spine, the spine section. So again, we're going to go in order in the body, head, neck. Then we go to thorax, so that's a chest wall, interthoracic, and then spine and spinal cord. And that's on page 76. Ooh, got this all bent. So spine and spinal cord, okay? So here, the very first one we have is 00126 600, anesthesia for procedures on cervical spine and cord, not otherwise specified. And this seems like it would be really great because I already said it's in the cervical spine. So that makes sense. We don't have a super specific code right here for the cervical spine. That would be ideal, right? But let's go ahead and keep looking through. This is for patients in the sitting position. That was not indicated, so we're not going to use that. And then we have the thoracic spine. So we know none of these for the thoracic spine is going to work because I've already told you it is the cervical spine. And it might help you to go ahead and make yourself a little cheat sheet up here. I know that like C1 through C8, I think, is cervical spine. So if that helps, go ahead and make those notes for yourself. And that kind of helps you narrow things down more quickly. So we know that we're not going to do thoracic spine again. Lumbar, we're not going to do that. Anesthesia for manipulation of spine or for closed procedures on cervical, thoracic, or lumbar spine. So down here, so we've got, I'll actually do this. This might help. If we can separate it out here, and then you can know right by looking at it that we're going to have thoracic, lumbar, and cervical. And other, I'll say other, or all. Because these could apply to any part of the spine, right? And so this is for manipulation of the spine or for a closed procedure. And we don't have any indication that it is that. In fact, we know it is not a closed procedure because they are doing extensive open procedures on this poor patient, right? And then we have here, this says anesthesia for extensive spine and spinal cord procedures with instrumentation or vascular procedures. So we don't have any indication that it's a vascular procedure, but we do know there's instrumentation and that it is an extensive spinal surgery, because look at all of this that we're doing, right? We are removing discs, discectomies. That seems pretty extensive, right? And so since this would apply to any portion of the spine, I actually think this is going to be a much better, more specific code to use, okay? So remember, we want to code to the highest level of specificity. That's how we get paid the most and how we can best reflect what is actually happening with the patient in the notes or in the codes. So if we did not have this code down here, then yes, we could come up here and use the not otherwise specified anesthesia on the cervical spine code. And if you use that, it might actually get accepted, but this one is much more specific and therefore better. So that's the one we're going to use, 00670. That's the one I would recommend using, okay? And then we do not have any information in the actual, I don't believe we had information in the actual report about the patient's physical status. So we're not gonna add that for this one, okay? Let's go back and see if we got it right. Oh, 670. Yes, perfect. Okay, so that is the correct answer there. Now, if you feel lost with this, that's okay. You are going to get more practice with it, and we're not leaving it here this week. We're going to keep practicing with it. I think the more you use it, the more comfortable you'll get, particularly with identifying when it's a very extensive procedure and those physical status modifiers that you're going to be using. A few reminders this week, make sure you read through the whole discussion. Don't just read your comments and see if I comment back. Read through everything, because that is the best resource that you have in this class, is getting to learn from other people and figure out what they're concerned about, and maybe see if I've answered something for them or if somebody else has answered. And you guys can definitely answer each other's questions. You did a great job at that last semester. So I am very excited to see you guys work together to solve some of these problems. And then, of course, if you miss a question, figure out why and use your resources. So that will mean using your medical dictionary, looking things up, figuring it out, right? We don't just shrug our shoulders and say, oh, well, I guess I didn't do so well on that one. No, we want to find out why we didn't do well, and what we can learn for next time, right? And practice, practice, practice. You cannot practice enough. So that's all that I have for this little video. I hope this has helped you clarify some of those modifiers. I hope you're feeling super confident. If not, put it in the discussion and we'll figure it out. Have a great day. Thank you.